hand you over to Professor Wass for the session. Thank you very much.
Well, Pat, it's John Wass here, and as some of you will know, I work in Oxford as an endocrinologist, and it's very pleasing to see so many people here to this newly diagnosed session, and thank you to the Pituitary Foundation for asking me to talk. I've prepared a few introductory comments just so that you've got a little time to think, and then the majority of the session will be open to your questions. I think it's the reason that I helped to found the Pituitary Foundation now 25 years ago was that I think it's fair to say that pituitary disease isn't common. And it's quite difficult sometimes to find somebody. If you've got a thyroid problem, it's very easy to find somebody up and down the street who's got one too, but it's not so easy to find somebody with a pituitary problem. And so it can be very frightening when you don't know what to expect and what's going on, and you sometimes find some frightening things on the internet. And so I remember talking to my son when I was thinking of starting the Pituitary Foundation, and he said, surely you've got enough to do. Anyway, I'm rather pleased that we did go ahead, and Stafford Lightman and Sue Thorne and myself started it up all those years ago, and we had a very good 25th anniversary a few months ago now. And so it's something which has gone on to flourish, and I'm one of the things I'm rather proud of is that having helped to start it is something which I think is good for a lot of people. The Pituitary Foundation has made it its business to provide information, and I think that it's really important that this is provided in an unfrightening way, because some of the things on the ordinary internet are frankly completely petrifying, and I think that it's also important that you establish links. And one of the reasons why we founded the Pituitary Foundation, and now there are very many regional groups up and down the country, and hopefully this is something you can do by joining a regional group and to form links with others who have pituitary conditions to discuss it, and therefore hopefully to understand it better and to be less aware, less frightened of the whole process. I think it's really important that as you go into this whole business, that you actually establish good contacts with the endocrine specialist nurses in the department, and there are mostly endocrine specialist nurses in most of the pituitary departments, and I'll come on to talk about them a little bit later. And then also getting to know your consultant and who that is, and making sure that you have the contact details should you need them. And that's an important aspect of ongoing care. So when you come in, you get diagnosed, and there are a whole load of tests, often done by endocrine specialist nurses, and they may take a little while. Certainly tests can take a few weeks to get organized, and then a few weeks more to get the results. And so there has to be a time when actually one is quite patient to try and know exactly what's going on in the pre-testing phase. And then when the diagnosis is made, usually there's a multidisciplinary team meeting, and this is completely obligatory now that all patients with pituitary problems are discussed with a multidisciplinary team meeting, or an MDT as we call it. And those meetings have an endocrinologist, a specialist nurse, a surgeon, a pathologist who can look at the tissue if it's needing to be removed, and they all conglomerate to provide an opinion based on their relevant facts. And this is something which means that we optimize the patient care according to everybody's experience. It's a team effort. And then if there's an operation, there's an operation, and then post-operatively there's testing, and again that may take a few weeks. Usually it's a fixed protocol, so that people with Cushing's, for example, will have certain tests, people with acromegaly will have certain tests, and people with non-functioning tumors different tests. And so that all takes a little while, and hopefully by then you've established a rapport with your endocrine specialist nurses and the team, and I hope and think that that's something which is helpful for everybody. There have been some difficulties. Pat and I talk sometimes about difficulties that are in contacting the specialist nurses, and this is particularly a difficult time because a lot of people who are endocrinologists are also involved with the care of COVID patients, and they come off their endocrine department wards and have to go on and do things. So there is a degree of shortness of staffing in a lot of endocrine departments largely because of COVID. Now, just a few words of advice, if I may. on outpatient appointments, because I think that this is something which is really important to you. I think that they should occur very regularly, particularly immediately after the operation. If there's been one, you're going backwards and forwards probably every few weeks or so. And it's important, I think, at this stage to bring a friend or a relative or a husband or a wife or whatever it is, so that you've got somebody who can actually, if you like, almost take notes. Some people do take notes when I'm talking to them, which I don't mind at all. Also, but to remember and to understand what's been said, because in fact, some of the data are what said that when doctors talk to patients, hopefully it's done in an empathic way, but actually not everything is easily remembered. And I think it helps to bring somebody along who can also bear witness to what's being said and also ask questions. And I think when you go to an outpatient appointment, it's a good idea to prepare a list of what you want to, like chairing a meeting. You need to get a list of what you want to achieve by the meeting. And you can either put it down on paper or have it in your mind, but have a list of what you want to know by the end of the meeting and what the problems are, if you've got problems, which you want to raise. And I think it's probably a good idea in the problem list to start with the ones that are most important for you and then go down to the ones that are less important. Now, some departments will get their patients seen by the consultants. When I was working in the NHS in Oxford, I always tried to see the new patients, and that's something which I hope and think continues. I think it's really important that there's consultant input into a new patient. But also, I think it's really important that you're entitled, if you're seeing a registrar and you're not clear or happy, you're perfectly entitled either before the appointment or at the time of the appointment to say you want to see the consultant, and they should listen to that. And I think it's important that you have access to the views of the consultant. One of the things I've done recently is to go around all the departments of endocrinology in the country, and there are 127 of them in England. And just for your knowledge, there are 23 departments of endocrinology in the country which do pituitary surgery. Now, some of these, and Pat knows this very well, some of these will do 60 or so operations in a year, and they're very experienced. When I went round, there were several departments who were doing 1 or 2 operations and 1 or 2 Cushing's patients a year. So one of the important things that you should understand and hopefully get access to is to know what sort of experience the department where you are is. And there are a large number. I would say that there probably are about 20 departments which are very experienced, and there are probably 2 or 3 departments which really aren't that busy. And I think in the course of time, the number will come from 23 down to 19 or 20. But I think it's really important that you understand when you're going to a team that they have a reasonable amount of experience. Now, the Pituitary Foundation is something which I think is something we can all be very proud of. And Pat, who's on this call, who kindly introduced me, is one of the specialist nurses who listens to calls and answers calls from patients. And I think this is a very important function of the Pituitary Foundation. And sometimes we'll talk about some of the things that she's asked. But most of the time, it's something which is very helpful to patients. And I think it's something which is a real asset to the Pituitary Foundation that she and others are involved with the Pituitary Nurse Advice Line. Just a few more things to say. There is currently afoot a new steroid card coming in, and I'm involved with the Addison's group. And we and the Pituitary Foundation are redoing all the advice papers, web things, and publications to do with steroids. And Helen Simpson, who's an endocrinologist at UCL, has been doing a huge amount of work getting all of this brought in so that it's safe and improves safety for patients that need steroids. And that's something that's important as well. Another thing to mention that is changing is the fact that diabetes insipidus is a name which gets confused with diabetes mellitus. And Pat and I and others have been talking recently about changing the name. And so endocrinologists are a sort of big family worldwide. So I've been talking to friends in Basel and friends in America, a man called Joe Verbalis, and these are the experts. And so the bottom line is that we're moving towards changing the name of diabetes insipidus. And the reason for that is that people get confused with diabetes mellitus, and the people who are experts like us endocrinologists and our specialist nurses and everybody don't worry about it. But people who don't know about diabetes insipidus get confused and start measuring the blood sugar and things. And this is something which has caused a great deal of misdiagnosis and mistreatment. And so that's why we want to change it. And it's going to be quite a big thing to change the name worldwide, but that is our ambition. And I just thought that you probably ought to know a little bit about that, and Pat might be able to talk a little bit more about it later. And then the last thing that we all do is research. And some of the things that are very, very important, and I've spent my professional life a lot of the time doing research on questions which are clinically important and trying to give an answer in a huge, large cohort of patients, which we are lucky enough to have in Oxford. And so we've been doing patient research on Cushing's, acromegaly, non-functioning tumors, prolactinomas. And one of the things we're engaged on at the moment is something which is called cyclical Cushing's. And this is a difficult one because sometimes the people have abnormal results and sometimes they have normal results, all within a space of a week or two or a month or two. And this can cause huge diagnostic confusion and indeed diagnostic delay. And nobody at the moment knows how often, for example, cyclical Cushing's is in a cohort of people who have Cushing's. And so that's just one of the things we're looking at the moment in terms of research. And so there'll never not be a time when we know it, but when we don't want to find out more. And so those are a few introductory comments, and they've covered quite a lot, and I hope they give you some stimulus for some questions. Are there any questions at this stage that anybody would like to ask that I can answer, or Pat can answer, or others can answer?
So one of the questions, John, is I have no access to a specialist endocrine nurse. I struggle to get help between appointments. How do I get this, please?
Okay, so that does slightly depend where you are. I think it's fair to say that all the pituitary centres have endocrine specialist nurses. Am I mistaken, Pat?
Well, the main centres of excellence certainly do or should. If they're under a local district, a general hospital, perhaps not.
Yes, and so if you've got a pituitary problem, you should have a sort of referral pattern from the local hospital into the main centre. And those should all have endocrine specialist nurses. One of the things that were in so one of my things of my visits around all the centres in the country was actually that in, I think, 73% of centres, we recommended that there was the appointment of an endocrine specialist nurse. And they are very, very important team members. They tend to have time to devote to empathically talking to people. And this is something which the report is only just coming out in the next few weeks, but it's something which I feel very strongly about, that every single department ought to have an endocrine specialist nurse. And actually, to give them their due, most departments want to have an endocrine specialist nurse, and sometimes it's difficult to fund them. So to answer the specific question as to you can't get an answer from you don't have an endocrine specialist nurse and you can't get an answer from your consultant, I think that's unfortunately not an uncommon sort of statement, if you like, but it's something which is important that you can write into the consultant, and I think that that's how to deal with it, I think, and to try and get an answer.
Well,
and so it
sorry, it was me that asked the question.
Oh, good. Oh, yeah.
Sorry, I've just unmuted myself. Is that okay?
Yeah, fine. Carry on.
Okay. I think the reason I'm seeing the endocrinologist privately. So I don't know whether it's because he's there for sort of standalone as opposed to, I mean, he is one of the lead endocrinologists, but I don't have access to any. So I'm an extremely anxious person and I'm not doing well with any of it, but I can't contact anyone. And I send in too many questions, I think, and then he doesn't want to talk to me.
Well, I mean, I think I know who you're talking about. I mean, if he's seeing you privately, I mean, he should answer your email within a day. That's what I do for my patients. And I think that basically it's important that you talk to him about the issue, that talking to people, talking to your endocrine specialist nurse or whatever else it is. I think you should talk to him about that because I think it's...
Yeah, I've asked specifically about it actually, but nothing.
Okay. Well, I don't know what to say over and above what I have said. I think, you know, it's perfectly legitimate for you to point out that, you know, you would like to have a view as to what's going on, and you need to be able to talk to them. And if I mean, I do patients privately now, and I liaise with the department in Oxford and with the nurses there, who I still know because I appointed them a few years ago. And so I think that should work actually, but I'm sorry if it doesn't. But I think, you know, a slightly tetchy email might be worthwhile.
Okay, thank you.
Okay, thank you. The next question, I am 8 weeks post-op. The aftercare information has been very disappointing after my op. I need information on steroids and COVID vaccine.
Okay. Okay, so let's do COVID vaccine because that's easy. You don't need any extra, if you're on steroids, you don't need extra steroids if you're having a COVID vaccine. I think that if you get a temperature and things, then you could take double your steroids for the time that you have a temperature or fever or whatever it is. But I'm now a qualified vaccinator after 6 hours of relentlessly boring NHS email technology. You know, they do vaccinate people, and I think just two things to say. Number one, take some paracetamol if you get the problems, and number two, on the second vaccine, there's quite a lot of evidence that if you take paracetamol the day before the second vaccine, that you decrease the number of side effects. And again, I think that if you're having difficulty with the post-operative information, I find that disappointing, because that you should be clearly, you know, according to a protocol, how it's all done and what you're going to have done when. And that's the job of the endocrine specialist nurses. I'm sorry to hear that it's been disappointing, but that's what should happen. And in terms of it happening, then I think you've got to email or write to the nurses or to the consultant and say that you're not happy about what's going on.
Well, that was, unfortunately, that was me raising that question. When I came out of hospital, basically one of the biggest problems I found was the discharge letter. So the discharge letter came home with me. It went to my GP with no information about my medication. And also, so basically the GP refused to give me my medication without any confirmation from the hospital. And then it wasn't passed on to the clinics. So the clinics actually thought I was still in hospital as an inpatient. They weren't aware that I had been discharged. So I was late receiving aftercare, and I've really struggled to get any aftercare information. So this is why I joined. I went afterwards. Once they found out they'd missed me, they did get me in quite quickly, and I was seen by an endocrinologist. And I'm now obviously in the system, and they will have an MDT meeting about me shortly. But what I really struggled with is not knowing. Everything just went wrong when I came home, and I was rushed back into hospital. I wasn't aware of what was supposed to happen after the app or what to expect. Things went terribly wrong a couple of days after I was discharged, and it was just absolutely horrendous. And I'm having real problems getting the medication. I feel like other people are going through the same as me, is that the medication, the levels that they put you on to begin with, and I understand that it's a long process, but I'm not doing well on the medication. I feel like I can only say I feel like a hormonal teenager and going through the change again, and I'm 60 and I've gone through both of them, and I feel like I'm going through it all again, and I'm having to wait weeks and weeks in between to be seen again, to change the level and have the tests again. And I don't know whether there's a way to speed that up, and I'm just not doing well on the medication at all.
Yes, I mean, I think Pat, we should put into our things for patients that they should, you know, before their operation, have a clear pathway post their operation so that it's explained to them. And I wonder whether we shouldn't put that into some of our papers, that this should be something that's expected. In terms of your problem now, I think that again, it's a question, do you have an endocrine specialist nurse? Because I think the other thing which is important is that when a patient is going through an operation in a specialist centre, they should have a sort of designated nurse to whom they can turn if there are problems.
Yes,
and
I have now.
Good.
I didn't to begin with.
That should have happened at the beginning, right?
Yeah. When I spoke to the endocrine nurse, she said she was supposed to be alerted when I was on the ward. She was supposed to come up to me on the ward to talk through things and give me the information that she gave me on the day. This is only just last week I've had the information, and that's how I know about this conference and everything. So she was really nice, and she said, why wasn't I alerted that you were on the ward? What ward were you on? And I told her what ward I was on, and I would have been armed with all the information, but I had nothing, absolutely nothing.
Pat, I wonder whether we shouldn't actually begin to think about doing a survey on some of the departments so that actually we can score them. And so, you know, everybody should be told before the operation what's happening. Everybody should be warned what's happening after the operation. Everybody should be given a nurse to contact when they're perioperative, and they should have a clear pathway post. And I think we could actually think about I don't know what you think about this, sort of having a sort of a questionnaire to patients who are going through their operations, and then we could actually score departments and see how good they are. And then if it gets publicized on the internet, we could actually get people to pull their socks up.
Well, the endocrine, just to expand on that, the endocrine nurse did give me it was like a feedback form when I was at my appointment. So I had the blood test where they check whether you're producing the cortisol. So I was there for quite some time, so I had time. So I filled in the questionnaire, and I am one for giving feedback, and I hope it does make some difference, because I would hate anybody else to go through what I went through. I had all the information before. The before and the actual hospital stay was, I can't fault the care. It was the aftercare and literally no information.
Well, Pat, I wonder whether we should, because the road to hell is paved with good intentions that don't happen. And I wonder whether it wouldn't be a good idea for us to do a survey of the 23 departments with the questions like, and we can think about this, with the patients, and we've got some lovely patients around the place. You know, did you get this? Did you get that? And then we can mark them out of 10. Because actually, I remember looking after a patient who had acromegaly, who was very involved. He was in David Blunkett's department. And David Blunkett started introducing things in the Department of Education, and all the teachers were very worried about it because he was actually getting information on how well they were performing. And I think actually that helps to bring the standards up. And I think that's a frightfully good idea. The more I think about it, the gooder idea I think it is. Pat?
Yeah, I agree. Obviously, we've got Pauline here, our endocrine specialist nurse, and we've got our helpline service, and I hope that we can offer you any help that you need. Obviously,
well, I mean, tell them a bit about your service, Pat, because it's bloody marvelous. And you get how many calls a month? Hundreds, don't you? Lots.
So
anyway.
we do. We get hundreds on our helplines, the nurse helpline, the information line, and we get over 100 helpline emails a month and texts.
And you two are very, very experienced endocrine specialist nurses. I mean, you really, you know, you're very, very good.
I'm actually not, it's Pauline. I know that it's very easy to get Pat and Pauline mixed up, but I'm head of patient family services and I'm not a clinician, but I've been a patient for 35 years and I've worked here for a long time, so experience, yeah. But Pauline's brilliant, so always speak.
Well, you're both brilliant. I think so I think I think I'm going to write it down, but that's a good idea.
Okay.
Right.
So our next question is, how do you find out if your endocrine unit is good?
Ha. Okay. So, I mean, the most important thing is how many operations. So let's say you have acromegaly or you have a non-functioning tumor. How many operations has the surgeon or surgeons done in the last year? And the minimum number is 20. And it's a perfectly legitimate question to ask. And now whether they're any good or not is something which is quite clear in my mind, that some departments are good and some departments aren't so good. But I think that the outcomes of their success is something which we're trying to, well, not trying to, we are putting it together, but at the moment it's not publicly available. But we're trying to get data which say, you know, if you've got a microadenoma causing Cushing's, this is the percentage of patients in whom there is a cure. The same for microadenoma causing acromegaly. And so there are ways of measuring the hormones, but at the moment, the most easy way of ascertaining whether your department's good or not is the surgeon, or are the surgeons operating on a reasonable number? Now, there's a huge debate around the world about what that number is. What my report is saying is that it should be at least 20 a year. I actually think the best departments are operating on more than that, up to 40 a year or even 60. But I think the minimum should be that the patient, the operation numbers is 20 per year. And then you can understand, you can ask them that. And you can also ask Pat.
Next question. This is a different one, but of the same theme. I'm under Bolton Hospital. Should I be transferred?
Well, Bolton Hospital is not a department which does pituitary surgery, to the best of my knowledge. And if you've got a pituitary condition, then it's probably better for you to, well, it's better for all pituitary patients to be looked after mainly in one of the 23 departments of endocrinology which does pituitary surgery in England. There are departments in Northern Ireland, there are departments in Wales, and there are departments in Scotland as well. But so the answer is, if you're a pituitary patient who's got a pituitary tumor, then the best practice is every single patient with a pituitary tumor should be discussed by a pituitary MDT in the country. Those are the rules.
Thank you.
The nearest to Bolton is probably Manchester. Oh, well, that's a good place. It's busy too.
Okay, am I all right just to speak? It's just I've been diagnosed, and they're not at this point after referring me, you know, to anywhere else. Should I be asking that myself? Be asking to be referred to a specialist centre?
Oh, well, have you got a non-functioning tumour or Cushing's or what?
It's a non-functioning tumour. It's 5 millimetres. Okay,
well, you should be referred. 5 millimetres is not big, and a lot of people wouldn't worry about a 5 millimetre tumour because they don't 5 millimetres. Yes.
Yeah, I think yeah, sorry, me. I've not been kept really up to date with my care, yes. But I think that's what they've told me.
Well, if it's 5 millimetres, you don't need to worry. And we've done work and published it that 5 millimetre doesn't change in size over the years. You just need a scan at a year. But I think that probably does mean that it's called a microadenoma, and you probably don't need to be transferred with that. But it should be that all patients with a pituitary tumour should be discussed at the MDT, and that would be the decision, that they don't need to worry. They do a scan in a year, provided they've done all the tests to make sure it's not making too much hormones.
Right, thanks for answering the question. That's why I've joined tonight, to get some further information.
Yeah.
Well, that's the whole business of the Pituitary Foundation.
Yeah.
That's good.
Thank you. Next question. There are several members of the Cushing's UK group who appear to have cyclical Cushing's. However, many are finding it hard to get the endocrinologist to test for this. They are often discharged after only 1 or 2 tests. How do we encourage them to do further testing for cyclical?
Well, that's something which we've been worrying about a lot, because I get asked to see quite a lot of patients who may be cycling in and out, and it's not widely recognized. And it's certainly, as I said earlier, not known how often patients cycle. So it's difficult. And I think you probably need to do at least 3 tests. So 3 overnight dexamethasone suppression tests, 3 urinary cortisol tests, and 3 midnight cortisol tests. And so I think unless you've got those, you can't be sure they're not cycling. And so I think that that's how it's done. But in fact, I think a lot of people don't recognize it, which is why we want to do this piece of research. And in fact, I've been ringing around various departments recently, and there are quite a lot of them who are keen to be involved, like in Birmingham, at Berks, in Cambridge, us in Oxford, obviously, and others. So I think actually the recognition of cyclical Cushing's as an issue is difficult, because a lot of people don't recognize how common it is, because we simply don't know how common it is. But I think that if you've got Cushing's and your overnight dex is normal, your midnight cortisol is normal, and your 24-hour urinary cortisol is normal, having said that, it's quite unlikely you've got Cushing's.
Thank you. I have adrenal insufficiency caused by overuse of steroids for asthma. This has caused Cushing-like symptoms. Would I be considered to have Cushing's, and is there any treatment for this, please?
This is something which is very topical. The respiratory physicians don't recognize that they cause Cushing's with high dose, high power steroid inhalers, but they do unequivocally do that. The only way of dealing with this is to, firstly, if it's asthma, you need to get a good respiratory physician to minimize your steroid dose. The only way of getting rid of Cushing's is to decrease the steroid dose, and that will be helped by having a good asthma specialist. And then the only other way of doing it is to decrease your inhaled steroids, and that will eventually stop it. But sometimes, and in fact, if you've got somebody who's got bad asthma, who's been on a high dose of inhaled steroids for ages, I will normally cut my losses and say, because in order to de-suppress the adrenals, you actually need often years of not having enough steroids and years of feeling tired and less well. I often cut my losses and say, right, this patient's got suppressed adrenals, she or he needs steroids long term, and you give them steroids according to what they need, according to the normal adrenal protocols, and you try and wean them off their steroids, because the only way of getting rid of the Cushing's and the only way of getting rid of adrenal suppression is to wean them off their steroids. And frankly, often asthma is quite bad, and often you have to go through, as I say, quite a long period of time when you're not very well, to try and allow the pituitary, hypothalamic pituitary and adrenal axis to recover. So I often cut my losses and say, right, you're on steroids, let's get them and your quality of life as best we can with you on steroids.
I asked that question, and I am on steroids now because my adrenal function was so poor, and I'm going to be on it forever, it seems, because my asthma and my chest is so bad they can't reduce my steroid input, really.
In those circumstances, you just need to make sure that the complications of steroids are not getting there. So you need to have had a bone mineral density to make sure your bones are all right. You need to have your cardiovascular risk factors, your cholesterol and your blood sugar and your blood pressure sorted out, so that actually everything is as good as it can be in the face of you having extra steroids, because there are complications of having steroids, but they can be sorted out. They just need to be anticipated.
And sorry, can I ask, would those tests be done regularly at my endocrine appointment, or would I get those from the GP?
Oh, no, I think they should be supervised and made sure that they're done by the endocrinologist. So in somebody with Cushing's, I will make sure their bone mineral density is okay, and you repeat that every 2 or 3 years. You look at their cardiovascular risk factors, their fasting cholesterol, their fasting blood sugar, and their blood pressure, and I look at those every year just to make sure they're all right, and to make sure that if they aren't, they get treated.
Okay, I haven't been having that apart from the osteoporosis risk, so I will ask for that at my next appointment. Thank you.
Yeah, well, the reason for that is that patients with Cushing's have a higher mortality simply often because of cardiovascular things as well. So I think that's why I always make sure that those risks are either present and treated or absent.
Thank you.
Thank you. I've had my initial MRI and it shows empty sella. This is my first step, and I've been having potentially Cushing symptoms for 10 years plus. I've now been given an appointment for what appears to be a test for Addison's. Is this test of value at all, as research suggests it's the opposite of what is required?
So I don't know what the person's weight is, but often people who are overweight have a higher frequency of empty sella, and that may be why there's a sort of interaction with the thoughts of Cushing's. The empty sella can either cause underactivity of the pituitary, in which case a synactin test would be useful. An empty sella can be associated with Cushing's, but it's uncommon. But those normal tests like a midnight cortisol, overnight dexamethasone suppression test, and 24-hour urinary cortisol are the things that you need to do for that. And so an empty sella is something which doesn't progress. It can be associated with normal function of the pituitary, or it can be associated with either under or over activity. And all of those need to be thought through and tested for before you get the all clear in terms of what the consequences of your empty sella are.
Thank you. And for reference, I'm significantly overweight and probably have been for about the last 10 years. So it sounds like it's worth having done at least almost to get.
I would get a synactin test done, but
yeah.
In terms of your weight, I would certainly get a 24-hour urinary cortisol. Make sure you have a dexamethasone suppression test, which goes to below 50, and make sure that you have a midnight cortisol, which is below 5.
So it's the Dex test.
It's
That's the one that I was expecting, I think. But okay, thank you.
But it can be either way, so get all of them done.
Okay, thank you.
Thank you. Next question, how do you know if you need growth hormone?
Well, firstly, the symptoms of growth hormone deficiency are very clear. The cause is of tiredness. You tend to put on central abdominal weight. You tend to have muscle weakness. You tend to have a high cholesterol and various other things. So in the context of having pituitary disease, that's the next thing, which is obviously important. Then if your quality of life is okay when you're on other replacement therapy, you may not need growth hormone. But if you do need growth hormone, the only way of telling is to have a test, a dynamic test, either an insulin tolerance test or an arginine test. And that way you can see whether the growth hormone goes up to whatever the local normals are, to make sure you are or are not growth hormone deficient. And then if you've got other hormone deficiencies, then if you're, for example, deficient of estrogen or testosterone or thyroxine or ACTH, then you sometimes need to be thinking of growth hormone, because the normal progression of pituitary failure is that growth hormone goes first, and then gonadotrophins go, so the sex hormones go, and then after that it's the thyroid and the adrenals. And so how do you know whether you need growth hormone? You need a dynamic test in the context of somebody who's got pituitary disease and is usually on pituitary hormone replacement therapy with either testosterone or estrogen or thyroxine or steroids. Does that answer the question?
Yeah, thank you, John. Thank you. Will I be on steroids for the rest of my life?
Crikey. Well, it needs a bit of background, that question. But usually if you start somebody on steroids, they are on them long term because they're hypopituitary. There are some exceptions. The problem with having a brain is you can think of all of these other things. But basically, if you're having an operation, some people who were on steroids before the pituitary tumor was removed, say a non-functioning tumor, 10% of people have an improvement in their pituitary function. So they may need steroids before the operation, but they may not after. But on the whole, 90% of people who are on steroids will need them for the rest of their life. And then in those circumstances, then you need to bring to bear your knowledge of the emergency rules, the what to do if you hit an infection and a fever, and if you can't take your steroids, then you need to wear a medical alert bracelet. You need to have an emergency injection given by your endocrine department to include a syringe and a needle, as well as an ampoule of hydrocortisone. And so you need to be very clear what extra things you need if you're on steroids. Otherwise, you can come to some harm.
John, that was me again. And again, this goes hand in hand with what I was saying. I mean, so obviously I'm only 8 weeks post-op, and nobody's discussed about steroids. I mean, I had my test done just last week. And
you had a Synaxin test, did you?
Yes, I did. And it showed that I'm not producing any cortisol. So
then in that case, they will need your steroids.
So, but they've reduced them. And so I was on something like about 300 milligram when I was in hospital, and I'm down to 15 at the moment.
The normal dose of replacement for hydrocortisone is 10, 5 and 5. So 15 is just a little bit below normal, but that's reasonable.
So basically, and the other thing,
I'm afraid you'll be on steroids for life likely now. If your Synaxin test is below normal.
That's again, I've not had any information about steroids and keeping. I was given a little card to carry around with me, but I don't know the effects of being on steroids, what it can do, and what I need to watch out for. I haven't got a clue. I've not been given any information at all.
Well, I don't think that's at all desirable. I don't know what you think, Pat, but I think that, if you've got somebody going on to steroids, you have a list of things that need to be discussed with the patient, including what to do in an emergency when you're vomiting, what to wear, a bracelet, what to have a spare injection. I think you should write to your consultant and say, look, I'm on steroids. What precautions do I need to observe? And please can I have a tutorial? And we actually in Oxford give special tutorials for people on steroids so that they can, for example, inject an orange and actually learn how to give an emergency injection. Yes, okay, well, you need to get hold of all those pieces of information.
Yeah, I didn't know nothing about that, John, sorry.
No, well, I'm afraid you jolly well should.
Can I just say there that tomorrow night our endocrine nurse Pauline is doing a live session. She did a pre-recorded sick day rules yesterday, and they're on our website. And we have lots of free resources. And if you contact us through our helpline, we can help you.
When I was a little boy, I did a film on how to inject hydrocortisone. I think it's been taken off the internet now, but it was very good. And there are films around. So I think that's a very useful piece of information, Pat.
Next question, which is quite in keeping. If on extra steroids, should one see the bone specialist regarding bone health?
I regard myself as a bone specialist as well as an endocrinologist. So most endocrinologists should be able to cope with bones as well. I think as long as you're getting a bone mineral density done, then the endocrinologist will know what to do. If your bone mineral, if you're below the age of 60 and your bone mineral density is osteopenic or better, then you don't need to worry. And you have a bone mineral density every, as I said just now, 2 or 3 years. But I think that if your bone mineral density is osteoporotic and you're over 60, then you need to think about treatment. And there are very effective treatments now. One is to have a weekly tablet of alendronate on an empty stomach, and that'll bring your bone density up in most cases. And there's now also a 6-monthly injection called denosumab, which keeps the bone density up, and that's also very helpful and decreases subsequent fractures. So that if you're osteoporotic, you do have an increased frequency of fracture, and you do need to have some preventative treatment, and they're now very amply successful preventative treatments for thin bones. And so the answer is no, you don't need to see a bone specialist. You need to go and see an endocrinologist who knows what he or she is about, and most of them should.
Okay. Next question. My respiratory consultant told me I had Cushing's alongside adrenal insufficiency, diabetes and osteoporosis due to long-term oral steroid, inhaled and nebulizer. We've managed to wean me off prednisolone and onto hydrocortisone, but I'm still on high dose inhaled and nebulizer steroids. I am still waiting on endocrine referral, which no one seems to be in a rush to sort. Should I be pushing this? I feel unsupported, but is an endocrinologist important in my case?
I would have thought it was, because an endocrinologist will understand about the sick day rules, will understand about how to give cover and so on, and also to optimize the doses, so that if you're on steroids, the doses need to be optimized and minimized, I suppose. So the answer is yes, you should be under an endocrinologist if you're on steroids with what is quite a complicated situation.
Thank you. I had an insulin stress test to check my growth hormone and cortisol. Is that sufficient to check both definitively? I have 0 estradiol and very low gonadotropins.
The answer to that is yes. So an insulin tolerance test will test cortisol, provided the patient is made adequately hypoglycemic. You squirt insulin, make their blood sugar go down. That causes a significant stress, which causes the cortisol to go up and the growth hormone to go up, because they're both normally stress hormones. So if you've had an insulin tolerance test, that will tell whether you need hydrocortisone and whether you need growth hormone. And it's likely you do if your estradiol is low and you're also hypopit from the point of view of your gonadotrophin. So the answer to that is yes.
Right, sorry, that was me again. The results actually came back, and he told me that both were the cortisol and the the cortisol and growth hormone were normal. So
oh, you said normal. I thought I heard abnormal.
You know, they came back normal, but I have none of my sex hormones are working, and I have no estradiol or whatever it is.
Estradiol, yeah.
Estradiol. But I have extremely rare diagnosis. I don't know if you would have heard of it. It's IgG4 hypophysitis.
Yeah, that's quite uncommon. But that actually, that specifically can affect the ACTH, your adrenals, but yours aren't affected. Your growth hormone isn't affected, and your estradiol is. Well, that's what. This is quite complicated. What you've got is something which is quite rare, which is an inflammation of the pituitary, and that can cause different axes to be deficient. And so normally speaking, in somebody who's got an ordinary pituitary tumor, growth hormone and then gonadotropins, then T4 and TSH go. But in hypophysitis, it can go in the wrong order, basically. So it sounds to me as if you're just estrogen deficient and you need estrogen replacement. If your cortisol and growth hormone responses to insulin are okay, you don't need them. And that shouldn't change.
Okay, so you don't necessarily lose all those other things.
No, you don't. If you've got IgG4 hypophysitis, that's a very uncommon cause of hypophysitis, and it's quite unusual, but that's what can happen. I've just looked at the bit in my textbook over the weekend for that. It's quite uncommon.
Do you think, is it, it's probably to ask you this privately, but is there anybody that you could recommend for this? Is it you, or I just don't know anyone that's seen, even my consultant, who I don't know if he's really ever seen this, and I'm just
okay. Okay, you've had a scan, presumably.
I'm due to have a full PET scan now.
Okay, but you need a scan of your pituitary to see whether it's enlarged. Sometimes it's not enlarged actually, but I think you don't need to see anybody else, to be honest. If you're estrogen deficient, you just need good hormone replacement therapy with estrogen.
I've got the DI as well. I'm having.
Oh, have you?
I've got DI and I've got that, and I've had the transphenoidal biopsy that gave the IgG4.
Well, you can get DI with autoimmune hypophysitis. That's definitely the case.
Yeah.
You don't need to see anybody specialist. To be honest with you, it's just a question of replacing what you're missing and making sure that that's done properly and monitored properly.
Okay.
So last question. From your personal experience, I have a macroadenoma of 11 by 7 millimeters. I have most, if not all, Cushing disease symptoms. I'm currently under the care of a new endo consultant after previously being dismissed by other consultant. In your opinion, with these symptoms and a tumour of this size, what is the likelihood of having Cushing disease?
I don't think you can't say what the likelihood is, you just have got to do the tests. So with a tumour size of 11 millimeters, I think you said, there's something going on that's not normal. And you need to have a urinary cortisol 24 hours, a midnight cortisol, and a dexamethasone overnight suppression test. And if that's normal the first time, I would do it again just to make sure, just because of the business of cyclical Cushing's. So the chances of you having Cushing's, I can't estimate, but you just need to have all the tests done to make sure you have or have not got it, because then the pituitary problem will need to be removed by a decent surgeon who does 20 or so a year. Does that sound all right, Pat?
Yeah. So that's the last question that we have. Thank you very much, John, for your time. Obviously, thank you to everyone that's brought their questions and attended the session.